Welcome to part 3 of fluid and electrolyte balance. Now do keep in mind that when a child is dehydrated, it's for a variety of reasons. And so all the principles that we're talking about in the fluid and electrolyte balance section is going to be pertinent to neurologic issues, respiratory issues, cardiac, GI, etc. We'll review briefly the pediatric fluid maintenance calculations. So for the first 10 kilos of a child's weight, we administer fluids at a rate of 100 mLs per kilo per day, and then we divide that by 24 to get the hourly rate. The next 10 kilos of a child's weight, we give an additional 50 mLs per kilo, and then anything over above 20 kilos gets an additional 20 mLs per kilo. And so you can see on these calculations how we come up to the child needs a total of 1,800 mLs per day, and that should be 75 mLs per hour. This calculation should be done at the beginning of every shift, and you need to do it repeatedly so you can do it quickly. After getting report, and you compare these values, if the child is getting 90 mLs per hour, you know that's about 20% greater than what is called for. So this kid was probably 20% dry. And we have to continually monitor this child's response because a 20% greater volume that we are giving can actually end up overhydrating the child. So this is your responsibility. So your nursing interventions are going to include monitoring the child. What is the state of their dehydration? And when you look at the child on the lower left, this is a very ill child. We start the IVs, and this is a challenge when a child is dehydrated because their veins are difficult to get to begin with, and then when there's a decrease in the intravascular volume, they're flat and very tough to get. We administer fluid boluses and then change out to maintenance fluid. You need to make sure that you accurately record the intake and the output. And remember, these kids, when they're very sick, they're just going to be laying in the bed. But once they start feeling better, they're going to reach for mommy and daddy's beverages. They're going to be reaching for their roommates' beverages, so we need to keep an eye on them. So the intake includes all sources, intravenous as well as oral. The output is also including all sources. And do keep in mind the insensible loss. We can't calculate it, but we might be accounting for it when we determine the severity of their dehydration. And then we will do weights on these children. So they're done once a day. We want to use the same scale. Make sure that you zero it out with the child wearing the diapers. And then compare that weight to the previous weight. Priorities in treating dehydration include the ABC approach. Make sure that this child has an open airway. Make sure that they are well oxygenated, and then very quickly focus on the circulation. And we do this by accessing a vein and giving them fluid. A child can have an IV inserted peripherally when they are severely dehydrated and difficult to access a peripheral line. We may give an intraosseous infusion. And yes, what that means is we are literally taking a large bore needle and we are putting it right into the bone. And then, of course, we have our variety of central lines, the PICCs, the Broviacs, Porticats, and in the newborn, for the first couple days of life, up to about 4 days, we have access to the umbilical artery or the umbilical vein. So here is a picture of the various sites that are available. And when you look at the left lower, the little gold circle, this is the access point for an intraosseous infusion. I like to have you look at pictures of where the veins are because many times when we're starting an IV, it's what we call a blind stick. We can't see it. We can barely feel it, and so you want to know where are those veins that I can access. And in the little babies, we actually can access the scalp veins. We just use a rubber band around their head to help that vein stand up. But sometimes this is the only place we can get. Here's a picture of the intraosseous route. And here's another one. We tend to use this more in a PALS type situation. We can use a femoral central line. And as soon as this kid perks up, we're going to take that out and put in a peripheral or some type of another tunneled catheter. And here's a picture of the umbilical catheterization. You are not going to do this. It's going to be the neonatologist. But you're going to be setting it up, getting the instruments ready, and preparing the solution for infusion. When we treat dehydration, our initial goal is to restore the intravascular volume. We replace dehydration losses with 0.9 normal saline. It's very important that you not give potassium in the IV fluids until you know for certain that this child is making urine. The 0.9 normal saline ensures that the fluid we are giving remains in the extracellular, meaning the intravascular compartment, and this will help support the child's blood pressure as well as improve the peripheral perfusion. We start out with a bolus of 20 milliliters per kilo, and we administer it over 10 to 30 minutes. Once that's completed, you're going to reassess the child's vital signs. And we sometimes give a second bolus, and other times we just continue with the rehydration process. And this is given a half of the child's 24-hour maintenance volume is given in an 8-hour window, and then anything remaining is going to be administered over the next 16 hours. And this is going to prevent us from fluid overloading this child. So, just to reiterate, dehydration fluid administration includes administering bolus fluids, normal saline, or lactated ringers at 20 milliliters per kilogram. Reassess the patient, repeat as necessary. We can give maintenance fluids, and this may be pertinent for a child who only has mild dehydration, in which case we would use the standard formula. And then we have replacement fluids, where we calculate the volume that's lost. We're going to add that to the maintenance fluid requirements and replace it over time. Bolus, and then give half the volume over 8 hours and the remaining balance over the next 16 hours. And this ends the lecture on fluid and electrolyte balance in pediatrics.